Call this meeting to order at 12:05 today. Our first item of business is public comment. Are there any comments from the public? No? Okay. Next on our agenda, approval of meeting minutes from our March 27th board meeting. Everyone have a chance to review those.
I'll move we approve.
Okay.
Second.
Any further discussion? All in favor?
Aye.
Any opposed? No. Okay, Finance Committee meeting minutes from that same day on March 27th.
And I'll move approval.
Thank you, John.
I'm the only other finance committee person here, maybe.
A little board has to approve it.
Yeah, no, I know.
Yeah,
I'm
you're
just looking for why there's no second popping up.
Want a second? Do I have a second? Thank you, Jim. All in favor of approving the Finance Committee meeting minutes?
Aye.
Any opposed? Okay. Let's move on to our hospital reports. Medical staff, do you have anything for the board?
I do not at this time. I'll be happy to entertain any questions you guys have.
Any questions for the medical staff?
We've, on the agenda, down below is kind of a restructuring of the lab conversation that we've been trying to have for a couple, 3 weeks. Tom Olding needs to be here for that, but hopefully Dr. Pafford won't get called away, for that, and we can do that. Tom, works half-time here and half-time in Plains at the Clark Fork Valley Hospital, and he won't be here till 2 o'clock, so hopefully we can skip to that discussion on the agenda.
I'm hoping we'll be at that part of the agenda.
Right,
when
right.
we get there.
Well, there's Laurel, good.
Oh, yeah.
Laurel, both the medical staff members would be an important part of that discussion too.
Dr. Pafford? In February at the Clinical Outcomes Committee meeting, you had asked to have the board consider sending you to a medical director meeting.
Yes, sir.
Has that happened, or have you?
Not that I'm aware of.
Okay.
I've not been approached by anyone.
Okay.
It just, it always makes good sense to take people in roles and say, look, we want to send you here for half a day, if nothing happens. Just let them throw a bunch of ideas in your head and come back out and say, oh, okay, good, I'll keep all those in mind and do my best to do that.
Is there a regularly scheduled type of meeting that you can go to?
I would say no, unless, maybe I could ask someone in the Montana Primary Care Association if they have anything to offer. From the Critical Access Hospital perspective, that's a different answer.
Is there someone at NHA? We've talked about this a little bit. Maybe being
Some peer.
some kind of a peer or a mentor.
We talked, I think
the
last
board,
time.
the board's all behind the idea of training, for sure.
Absolutely. Me too.
Yeah, training is good.
We just need to move forward.
Yeah. Okay.
Yeah.
We talked about getting you together also with Dr. Mullen. I know he's been chief of staff, I think in Spokane, and of course, bigger size facility, a little bit different situation. But, certainly he has some experience with all that, so we'll follow up and get this done.
How are we doing with staffing and not burning you out? And Laurel not burning you
Well,
out?
I'm pushing back just a little for a little while.
Okay.
I'm just trying to recoup my mind. Laurel, how say you? You doing okay? Laurel's a trooper at Providence, we're all troopers. I think for the time being, certainly the schedules are as far out as May, and I know Ray's working on June.
Okay.
Yeah, I had a discussion with Ray this morning about June, and making sure that you and Laurel you are our core providers, and make make sure we take care of you. I mean, it's been 1 day a week in terms of the coverage, I think. 1 or 1.5, and Dr. Pafford has been pretty great about filling in when we're short on the schedule. It's most appreciated. But we will certainly give you priority on that schedule. Fill in with.
When I was graduating, I'm going to the graduation.
That makes sense.
Yeah. So, little things, just, okay, need to take time to do specific life things so everybody wants to come to work and work hard. So we're working on that.
Well,
We
the
have-
clinic's working on bringing somebody else in for a day a week too, that hopefully will also.
Be able to allow
help.
them to have time off.
Sure.
Yeah.
Looking forward to that.
Yeah, so that should help.
I know we've been looking at getting help as well, so.
Yeah, we have quite a few people. Well, yeah, we've been talking about some increased hours. 1 PA and stuff, sure.
Anything else, any other questions for the medical staff? Do you have anything, Laurel, that needs to be brought to?
I think so. We're hopefully getting better at NextGen. Next week, we're having clinic retrainers and coming, we have lists and lists of questions that hopefully we'll get a lot of little clinky things worked out, but I think we'll get there.
I had a question about the chief, so was there an official vote from the medical staff?
My understanding that.
As far as chief of staff?
That the email vote met the requirements of our bylaws. Julie gave my leads to help set that up.
Sure.
And I believe I received an email that says, congratulations, your CMO.
And you said, oh, good.
So that did happen officially then, I just wanted to,
I think that constitutes an official.
an official vote.
And our med staff is usually last week, but it had to get changed because people were out of town, so
Yeah.
it's next week, I think. So we haven't had the official, but
Okay.
Julie sent out emails, so I think it's all official.
Okay, so there has been a vote, so we
Yep.
can,
Yeah, Julie did do that email.
right, right. I just wanted to make sure the board was aware of that as well, so. CEO report? Thank you.
Actually, I don't know that I really wanna, I think most of the stuff that I really wanna cover, I've sent update reports to the board and the foundation board just yesterday. If you haven't had a chance to read that, it's not in the packets, I sent it out by email yesterday, but, I think I'll just save my comments. Most of them are oriented toward follow-up with the budget and cash flow discussion that we had last week, and
Okay.
I updated kind of for background information, for everybody. I just updated in that little memo that I sent to the board last month that we talked about, and there's a number of action items, sale of the Mueller House, Traveler House, that kind of stuff, and the clinic building. I mean, Kim is here, we can talk about that with a little bit and report to you on that down on the agenda.
Okay.
I don't know that it's, you probably all don't want to hear all my long-winded stuff. I think I've been keeping you pretty much up to date with the update reports and some of those things.
Okay. Thank you, Larry. NextGen report. Would that be?
Deb
Deb
and
and
Ray,
Ray?
yeah, Deb and Ray. And Dr. Pafford.
Just perfect timing.
With food in your mouth?
Well, NextGen has been moving along. It's been occupying a lot of our time. We have a lot of people involved, but I think for the most part, people are using the system and really trying hard to get through things. We are looking at dropping some claims probably by Wednesday of next week, which would put us in about a 45-day range of going live and submitting claims, which I think is a success from my perspective of setting up a whole new system and being able to transmit claims within 45 days. So there will be some that that don't make that 45-day hit, but we are gonna transmit claims, live claims next week. As Laurel alluded to, and I'll have Ray touch a little bit more on it, one of the things that we have asked NextGen to do is come back and do one more training session with us. And primarily that will be nurses, CNAs, and they're going to bring somebody that can spend some time with the providers as well, which will help that last push, I think, to get us through some things that they've had questions on that we haven't gotten answers on, and continuing as they're going through different scenarios with patients, things that they're running into that we need to identify and work through. So, from the financial perspective, we don't have charges. A lot of the charges we're going through every account piece by piece and making sure that every charge is in there, that every order has crossed, that everything is going on from a non-clinical perspective. I then have to go to a lot of clinical people to get answers, so it's very time consuming to do that, but we're making sure that everything is crossing in the system and working, and that we have captured all the charges that we need to capture. So, and if not, then we're going in and making sure that it's not a problem in the system. If it is, then we're getting it fixed, and if it's not, then we're adding the charge in and knowing that it's been fixed already, and the next time it happens. So, Ray, do you?
No, that was pretty good. So next week we are having the people from NextGen return to us with some more training. Again, the providers will be trained as possible. It's a really good 3-day window as far as the providers that will be working on the floor the day that they're here. We'll have KT, Laurel, and Dr. Pafford in that order on the days that they're here. I'm going to bring in per diem staff for a couple hours so that they can get both put into the system and trained, so we can call on per diem staff and expect them to be up to date with NextGen. And then I and Angie Mellon are also going to work with the provider trainer so that we can kind of serve as a fallback for the providers, should they need somebody, for what that's worth, but hopefully it'll kind of bring us up to speed with some of the challenges that the providers face that we're kind of unaware of from our end of the nursing part. So we are moving forward. There was a shutdown of NextGen over the weekend from what I understand. It was resolved pretty quickly, but I'm understanding that it was inadequate server space that shut it down, but everything was handled properly. I got a phone call at home and just basically said, you need to get on paper right away, so we have all this stuff documented, and then we kind of contacted the appropriate outlets who got it resolved really quickly, again, from my understanding. So we're working with it when it works, and we're working with it when it doesn't work, so.
Is that the only time that that's happened?
It's gone down twice now.
It's gone down twice. In what kind of time frame?
Well, since the 18th of March, that was the go live date.
So just over a month.
And it's I think it's a real problem as far as our experience from the clinic would say, all the same stuff, so it's just life. When you live in rural, you don't have, it's just the way
One of the
it is.
issues that we're
Sometimes
trying to get addressed is the server, the size of the server and the server space.
Now, isn't NextGen our host?
They host our server.
So, is it
there's an
NextGen
issue,
that has an issue with the server space?
evidently.
Or is it just not enough assigned to us?
Well, we're trying to get that resolved. When we were doing testing in January, they had to shut the system down because we were out of server space. And at that time, we only had 300 to 400 accounts on the system with very limited clinical information in the system. So we had asked at that point if it was gonna be an issue. I think it was the first week that we were up on the system that we lost it for almost a full day. We re-asked again if it was shut down because of server space. That never really became out as the issue. They had done an update that day on some stuff, and they said that was the reason that the system was down, because of an update. We told them we need to know about those updates so we can prepare for them, so they have us on the list for updates now. But last weekend, the server, this going down, and now finding out that supposedly it server space, we're back out there saying, what is our server space and why is this happening? So we're trying to get an answer from the hierarchy of NextGen.
Is this something they're gonna address when they come next week?
I doubt the people that are coming next week will have any answers for the servers.
Okay.
They're clinical trainers.
Oh, okay.
Lose data?
We don't lose data, or we haven't lost data, because that should be backed up in their system. The problem is you can't enter data, so then you have to put everything on paper, and then when the system comes back, we
Then
should
you
be
have to
going
enter.
back in and putting everything back into the system, which, you know, is double and triple and redundancy.
Very inefficient.
And for a system to go down this often, I mean, we were told their downtime is like 99.8% or something, they're up, and so the first time we went down, we exceeded that expectation for a year, so, so we're just trying to get answers as to why it's happening, and do we need more server space, or is the size of the server have to be upgraded, or, and I'm sure if that goes, then there's gonna be a cost to that. I mean, it's a question that we've been asking since last June that I'm aware of, so.
Are we current on all of the upgrades at this point?
I believe that there's one pharmacy update that we may not be up on 2.6, which is the latest version. But it does not affect what we're doing in the system, and that will come along to us, but it has no effect on what we're trying to do.
When do they expect the next upgrade? I mean, so how much time do we
Yeah,
have
major
to?
upgrade.
We don't know, 2.7 will be probably the next upgrade.
Are we
which
looking at maybe a year, or?
We haven't
We don't know.
got any kind of a date. I mean, 2.7 has been promised out there. What 2.7 supposedly does is that idea that Steve Carty was sold when he looked at these two, that the NextGen ambulatory side, which is what the clinic is on, and the hospital inpatient side will then merge,
We'll be able to talk.
and we'll be able to talk back and forth. So I don't know when that update is out there, if it's 10 years from now, or if it's, you know, in a couple of years. They really haven't given out those dates.
No, we should jump in here and say, we've had quite a bit of conversation with the clinic, about ABN notices and some other things that do come across, or they're working on to make sure that we're working together to make sure that we both get paid properly. Some things that happen on the clinic side with the providers are real important to make sure that we have those advanced beneficiary notices in the system, and they're processed, and it's some additional revenue to us, so it's an important issue. And, the clinic folks have been very accommodating. We've been working back and forth. We meet every couple of weeks. We've been meeting with Kim and the staff over there, and Deb has been, addressing those issues back and forth.
So that's one of the interfaces that we have built, because 2.7 isn't there. We have an interface that was built in tests that we're still doing some testing on, and what that will do is it will link our lab results, and that will go back and forth from the clinic. So when the providers put in a lab order from the ambulatory side, it will cross to our inpatient hospital side. We can pull that order up, do the testing, and then the results will go back to the ambulatory side. We're working on that. The second thing is the ABN of having the diagnosis and the medical necessity in both systems, so that when a lab is ordered, we make sure that we have the medical necessity diagnosis codes on there, so it will be paid for through the Medicare systems. And so there's really two different pieces going on there.
So with this 2.6 system, I know maybe this is apples and oranges, but, are we gonna be able to be ready for ICD-10 implementation?
They delayed.
ICD-10 delayed.
Did they delay it again?
They did.
Till when?
Still, well,
October.
2015, so there's another year and a half.
Right,
Um,
right.
and they haven't set a date for 2015. They say, what the what the delay says is after October 1st of 2015, so there's really not a date set yet. But we know it will be after.
Okay, just.
Yeah.
Took a little pressure off us.
Yeah.
You know, as we train on ICD-10, part of the push is to not stop training and not stop testing, because we need to get people involved and providers understanding what all of ICD-10 is going to bring. So we probably, not that we're going to do it today because we're still involved in a lot of other things, but doing ICD-10 is still on our forefront and on our priority list as far as Julie and I are concerned, to try and work with everybody to get everybody, and to get testing done to make sure that we're doing what we need to do there. So did you have a question or a comment?
I'll bring it up later, it's
Okay.
just.
And from the
for
ABM
legal
side,
issue, I've noticed in the way that information's coming from the lab and going to the hospital, it should be in the hospital record.
okay, so we can talk through some of that stuff. I think it's confusing right now because we're not
More integrated.
more integrated. You know, when those faxes come to the business office for Dr. Pafford to refill a med, we're not sure if it's a clinic refill that they're trying to do or a hospital refill, so some of that stuff we really need to.
We have a lot of labs showing up on the hospital system that are clinic labs, but it's
Okay.
very confusing on the hospital side because our patients go to other places, and when your hospital providers having to sign for medical legal leave, that creates a big hit
Right.
of badness, because now you don't know what you're signing. It's a bad situation that needs to be resolved, and
Okay,
I've asked about it before.
is that on your list for next week?
I don't know if there is one.
Okay. Make sure that we,
Now is the chance. It costs about $20,000 to $25,000 to bring those people in next week.
or email me with, if you guys are running into things and you're not emailing directly to Monica, you know,
I
write
have
them down or
38
give me a list or
I had
whatever.
38 labs today from the clinic and the hospital to sign together in the same pile on the computer. It should be signing the clinic labs and the hospital.
Oh, those are all coming to the hospitals.
Most of them are clinic.
Okay. Is that a code or a program or a module type of issue?
It's
that somebody-
evidently how it's pulling to the,
It's a program issue.
So it's a program issue.
NextGen.
Do we have people in-house that are fixing some of those bugs, or is this something that NextGen has to
well,
come in?
as things arise, we
As they
send out a
arise.
group to an email group.
Tanai's aware of it and has been working with them. It's on our list. Dr. Pafford's added stuff to the list. KT's added stuff to the list. It's on there, but I don't know.
And ultimately, try to look at it a little bit like I do. Ultimately, what it means is every time we run into issues that we do run into, all the time, every day,
Yeah.
that's not much of an exaggeration. It means we have to spend more time sitting in front of the screen instead of sitting in front of patients and their family members, and they talk about it. And they're vociferous. They let me know
Right.
how displeased they are that it takes us so long to get off of those computers and to come talk to their mothers and their family members. So I do not exaggerate. So everything we can do to improve this process, because it's a small community, small voices carry far here.
And I heard people screaming about the 72-hour wait for prescriptions to be filled. Is that, that's a clinic?
Well, is Monty still over there? We can have him come over and talk about that. You know, we were down at the Senior Citizens Center, Monty and I, last week, and we had 3 people attack us, you know, mostly from the perspective of the clinic, but the public doesn't differentiate between clinic and hospital in the community, as we all know. And the complaint was, well, we can't get these prescriptions refilled. It's all the clinic's fault. It's all Dr. Pafford's fault. It's all Laurel's fault. And Monty, right away, came back here, talked to Regina the next day, and every one of those complaints, 3 of them, were totally and completely incorrect. So, you know, we've got this community has this way of spreading this stuff around instantly.
Notice that, huh, Larry?
Well, I'm used to it. I've been around small hospitals and small towns all my life, but this one takes the cake, I think. Yeah, I think I've said that before.
I don't think so, it's been a lot worse than that.
Well, I don't know, but Monty did a great job with it. He came back, talked to Regina, and, you know, every one of the issues were communication problems with the pharmacists, with the pharmacy. We won't say specific, you know, some of them are, they're not all here in Superior either. I mean, some of them were out of town and stuff. They were different situations, but every one of them, the issue was the pharmacy, not the clinic, not the hospital. So, you know, I think it's important that I thought Monty did just a great job of, you know, jumping on that and, you know, and getting back to those people. He got back to them and, you know, and made sure that they understood, that they kind of stopped that rumor, you know. I think that's the right thing. It was a great, it was excellent. It was, in fact, he and I both went over there, mainly me, because, you know, it's the only way I can get a good meal is, you know, if I have to cook for myself, it's hard to starve that probably, you know, it doesn't look like it. But, I went over last night also to, that was last week, all this stuff happened last week, and the three people that we were hoping would be there and we could kind of talk to them and make sure that they clearly understood that it was a pharmacy issue, did not come back to the, you know, Monty had asked them kind of to come back and talk to their friends and folks, you know, make sure that rumor was kind of stopped. So, but we, you know, we put a kind of stop to it last night. So, you know.
Can we finish up with the EHR discussion? I just
Sure.
had a general
Sorry.
question for all of you. Do you feel like, I mean, I know that as you work, things come up, issues come up, but do you feel like they're being resolved and we're moving forward? Is there a mechanism to?
Well, I kind of think, like, in my opinion, there's a point that there's lots of subtle issues that are hard to explain via sending tasks and sending whatever. So when we decided to have the trainers come back, then we just started a list instead, because I feel like it's hard to say, sometimes you don't know if you're inputting wrong, and that's why lab's not getting it right. I don't think that's the case, but it's hard without someone sitting there and saying, okay, I put in this, I said create order, send, and lab's not getting it correctly. It's hard to, do you know what I'm saying? Without someone sitting here and then seeing those issues coming across, it's just hard to convey. So I'm like, there's lots of things such as that. Some stuff tonight can fix right there on the ground, you know, like for instance, the other day I tried to order a lab and found out I could only order it on Wednesdays and Fridays. Well, that doesn't make sense. He can fix that, you know what I'm saying? But on the flip side, some of the issues that we have, until somebody's sitting here and you can actually see the way you're inputting it, that it's correct, and then looking at what lab gets spit out to them to figure out the whole problem. So I think there's lots of issues like that. There's the issue of the labs coming back that are clinical out that I know tonight's been working on, but again, when somebody sees it, then they might be able to go, oh yeah, we get that. So I'm hoping that a lot of those.
You guys are able to identify the problems and so that they can be addressed?
I hope so. I mean, we have a big old fat list.
Well,
Can I-
you have,
can
I mean, that's the
jump
first
in a
part.
little bit? There are process-related problems. Order entry is any kind of invoice, put it as a mark, doesn't matter what it is. There are issues with all the various types of orders and things. That's fine. That's the kind of things that can be worked out over time. The kinds of things that have not been worked out apparently for quite a long time and won't be worked out, I don't have any confidence in, is specifically the provider documentation templates are horrible. In fact, I was sitting down with our utilization review person today. We were trying to figure out how to add one or two admitting statuses that we haven't already. That's easy. That's a tonight project. He can get on that at some point. But the real issues are you're looking at the notes and there's these half-baked templates that NextGen, and I'll say this publicly, the NextGen's made in the past, they are half-baked. And as a result, you get, for an individual assessment on a patient, it'll tell you that the patient's issue is all three: resolved, improved, and worsened, all at the same time, in parentheses, because those are NextGen generated new issues, and every time I'm asked about it, I'm politely shoot to the side.
By NextGen?
NextGen, our own people can't fix it. We don't make the templates.
Right.
You know, and one of those wonderful NextGen people sat right next to me, and I had to show him what goes into a standard H&P one day. This isn't anything Dr. Pafford thought of. This is basic medical school first month stuff. Okay? He looked at me with astonishment and said, well, you could just type it in and click keep as a template. That is their solution to our documentation problems. You just type it into that box there and type save, and then you can go back and type whatever you want in the future. And that's exactly what they're willing to offer us. And we just need to be clear on that, folks. I have no love for this medical legal pinhole called provider documentation that is in the software.
Are we being reimbursed, when NextGen comes, like the $25,000 expenditure?
No.
We will not get that through meaningful use reimbursement?
Oh, well, the status with meaningful use, before the go live, we had paid NextGen $450,000, my round numbers. Cliff just released, Cliff would be here today, but he's ill. He went home. We just this week released $278,000, so what's 450 plus 278 is what, a little over 700,000. Our capital lease is capped at 700,000. Okay, we don't really know the extent of our meaningful use payback. Okay, until we actually go through it. In fact, well, we had a lady over from Mountain Pacific Quality who is the statewide expert on meaningful use Monday, and you know, our goal is, you know, correct me if I'm wrong here, Deb, but our goal is to demonstrate meaningful use. You have to demonstrate it for 3 months. What about the June, July, August timeframe, or even sooner if we can get it? But it's probably going to take that long before you're really, you know, comfortable in the system. And then once you demonstrate it based on whether you meet those criteria, you know, as we've explained to the board before, that round numbers, 700,000 plus or minus, comes back to you, you know, through the meaningful use payments. Also, those meaningful use payments are spread out over several years, you know. To get us over the hump, you know, with all of that, there is a, you know, this 700,000 capital lease, you know, and that's what's taking care of those expenses now. But we've exceeded the $700,000 estimate, and that 20 to 25,000 that I was talking about is in addition to. I mean, we have to pay an additional fee for that, for them to come back out.
The meaningful use numbers that we're seeing in the system, and Ray can probably speak better to it than I can, but we are seeing very good meaningful use numbers on the data that we're collecting.
We're meeting the criteria
We're meeting
for
the
the
criteria
standards.
in all the categories, and so it'll just be a matter of us deciding which 90 days we want to report, and we can start reporting in May, June, July. You know, our goal was to start April 1st, but we just don't feel we're ready to attest to that yet. We're feeling we're just a little too soon on that. So, but the sooner we do it, the sooner that we can turn around and say we met the 90-day attestation period, we passed the meaningful use, and now we can turn in to start getting our money back. And so that's the date that Cliff's waiting for, and the sooner we can do that, of course, the sooner we're gonna get money back. But our meaningful use numbers look very, very, very encouraging at this point.
What's our target right now? What's our target date?
May 1st is what we're shooting for at this point. You mean to start attesting? Yeah.
And then it's 90 days after May 1st.
You have to
3
attest for
months.
90 days, yeah.
Okay.
You have to have 90 days or
Right.
3 months, or whatever it is, of data, you know, that shows you met the standard.
Do any of these issues, you know, with the system going down and some of those things, does that interfere with any of our meaningful use? Does it hinder it in any way?
It hasn't.
For having to work through some of these bugs, does
And I
this
don't-
No, when
hinder
the
it our
sys-
meaningful
when the
use?
system goes down, we're not using it,
Right.
so we
But-
have to be using it to reach meaningful use, it's.
Is
And
it a
just
certain
to-
number of hours
It's
that has to be used?
Some of it's
Percentages.
percentages of claims and percentages of how many lab tests went across I mean, it's that kind of stuff.
How many,
You know, collecting.
How many CPOE orders?
Discharged with
Computerized
proper
orders.
instruction and then
Yeah.
medication reconciliation and stuff like that.
And just
We're,
to-
again, we're meeting 100% of all of them, some numbers better than others, of course, but I mean, if we were to submit it right now, we'd be good. Wouldn't have done it for 90 days, but, you know. And we have to keep in mind too, that the 90 days has to be complete by the federal fiscal year, so we're looking at
Yes,
October 1st.
Sarah Leak, the lady that was here, emphasized that to us several times, that the last drop dead date, to certify is October 1st. If we don't certify meaningful use, if we do not get certified, we will lose the $700,000. And so it's very, very important that we, meet those standards by the 1st of October.
That's another good reason to start May 1, because if
Exactly.
something's wrong, you've got more.
Yeah.
But the
Months
meaningful
left to-
use doesn't.
We have an extra month or two to,
Yeah.
The meaningful use does not address the types of things that Dr.
No.
Pafford is
No.
talking about. You know, how many of your patients went home with instructions? It could be all of them, it could be that 10 of them just didn't do it on the computer. I mean, so the meaningful use stuff, is there for government collection, and paying for our system, but really in a patient care world,
It's not very relevant.
it doesn't, no, it's not relevant to what, the kinds of things that our providers are running into.
So when we call them in for help, like Dr. Pafford was describing, then we have to pay extra each time we do that, it sounds like.
Yeah, I'll talk to you in an executive session about why that's happening, probably.
Okay.
Okay, Laurel and then Jim.
Oh, so just to clarify, I don't think just so everybody gets an idea, as far as the downtime, I think is the least of the issues, in my opinion. I think it's the same, I don't think it's a NextGen problem. If you talk to people who are on Epic, it's the same. Our
Right,
NextGen
exactly.
clinic is serviced, I think, through our own service, there's community, I don't know, but we have issues all the time. But
It's
again,
an EHR problem.
it is, and I'm it's just different than
Epic
looking
or
back.
Cerner or any of this is-
Exactly, before we had that, then some days you can't find a chart. Do you know what I'm saying? It's not, I don't think that it happens any more often than it did in the past, and it would be no different than in the olden days. Sometimes you couldn't find a chart, and then voila, there it was the next day. But it happens all the time. This morning, ERX was down, nobody knows it till you push the button and you go, that's weird, it got rejected, that's weird, and then, 2 hours later, you get a message that says, sorry, ERX was down, it's restored.
Wasn't that one of the great
Just happens.
promises of everyone going to EHR is that those types of issues would be gone, and that's just not the case.
No, it's the same as a computer.
Anybody that believes
I know,
that,
but wasn't that one of the big selling points with EHR was that, you wouldn't be missing XYZ, and, I mean, it just,
that was the guy sitting in DC
I know, it
working on
just-
paper that
it's
said it
ridiculous.
looks good on paper.
yeah.
The reality is, no, it doesn't work that way.
And it's just gonna happen, to me, that's just like an expected consequence of using your computer. Some days it works and some days it doesn't.
We're ahead of the game in the sense that most large hospitals have burned every piece of paper they have in their facility. We've kept everything around them, at least we can go back to it, and that's saved us, I think, the 2 times. Not saved us, I don't want to be that dramatic, but it's sure helped
It's
us.
been beneficial.
Yeah, absolutely.
Jim?
Well, I'm just thinking, you alluded to the server going down twice. Dr. Pafford's explanation of how you're gonna sit beside somebody that doesn't know what he needs, what he wants. I wonder if we shouldn't be writing a strong letter to the management of NextGen, saying there's some big pitfalls here that aren't being taken care of.
We're not quite.
Let me just address that, I have to be careful, I guess, but, the decision was made before I got here to go with NextGen. And as the attorneys have told us, the contract was never reviewed by an attorney. And there is no leverage in those contracts to do anything with NextGen. They're,
It seemed to me.
so we can write the letter,
We can
but,
at least, yeah.
we can write the letter, but
Indicating to
we
management.
have no leverage with NextGen.
I understand that.
Yeah.
But at the same time, the person that's working with Dr. Pafford can solve that right there on the spot. Management did not know what occurred at NextGen. I'll bet you management at NextGen does not know the server for this hospital went down twice.
Well,
Well,
could
they
be,
do.
could be.
Do they? They do.
The management?
Yes, they do.
Okay.
They are aware of it. And some of the stuff that Dr. Pafford's talking about as well is part of how some of these electronic health records are built. The template stuff in the NextGen system, in the ambulatory side, it's sort of the same way. Now, I'll speak dangerously here, Kim, but as you see certain types of things come up, you're doing a well child check. You can build, and what the idea is you go out and build that template for yourself to say, these are the kinds of things that I do in a well child check, and so I want to build that specifically for me because Dr. Jones is not going to do it the same exact way that I'm going to do it, and so they
And
leave
that's
that
what I thought it
flexibility
was,
of doing that, and I don't know if that's all of our problem or not, but we have not spent, NextGen has not spent, and our providers have not spent a whole lot of time looking at any of those types of builds and customization in those templates that I'm aware of.
I
Are you
spoke
aware of?
with NextGen directly, about 3 or 4 months ago, and they just let me know that, they were not interested in my input on
Okay.
the matter.
So we will tackle that.
And you do not have, don't compare the clinic product to the hospital product.
Oh, exactly.
Ne'er the twain shall meet, okay?
Understood.
The ability to modify the clinic thing, yeah, we can talk about it and play with it and attempt to do things. We don't have that on the hospital
Okay,
side.
okay. Because that's what part of the product, the selling of the product to me and my understanding was we would be able to template and build those same sorts of things similar to what we're doing on the ambulatory side. So, I need to understand
When it comes
that.
down to the provider documentation part, this goes back to, it's a long-winded story, we don't have time for here, but I do know enough about it to know that they hired somebody a couple years ago, back when we originally joined in line, and they introduced them to the software package. Okay, nothing ever became of the documentation.
Okay.
4 months ago, there was no difference. Now, what they did between 4 months ago and now is generate a couple of new templates. The problem is these provider templates include nursing stuff that doesn't belong in a provider template.
Okay.
Okay, and some of the stuff's out of order, it's in the wrong place, and we do not have the power to change those templates here.
Okay.
And the people who will come to train us do not have.
Do
that
not have the power,
That is
and
not
I
their role.
understand that because it's not builders that are coming, so
So
I,
I'm just registering my concern for the medical legal aspect. If we had a problem today with a patient I have in the hospital today, and you take that note into the courtroom today, it says on there that she's doing better, worse, or not improved at all at the same time, on the same problem for 1 out of 4 problems for this patient. It looks bad. It looks like we don't know how to practice medicine.
Don't you can't, make a choice.
Well, that's
I
the
mean, I don't
problem. I
understand.
can take you all down the hall after this meeting today.
And you
Show
can't
that
make a
you
choice.
cannot, these templates are broken, B-R-O-K-E-N.
I will find out.
And you can click on a thing, and you
Yeah.
click on this thing, they're contradictory, and you can't get rid of one or the other, and it's broken. It was never completed. It was a half-done job at best.
We will certainly,
So-
work with the expensive
You can
folks that
follow
are
up,
coming next
yeah.
week to make sure they can see.
And I'm happy for them to fix it.
Hasn't NextGen been out there for years?
They acquired the hospital product when I was an employee of the facility in
Yeah, it's
Musqueam.
not that old, it's
They
really.
bought the product from somewhere else. That issue was the least of their concerns apparently, because when I reviewed the NextGen product about 4 or 5 or 6 months ago, when we were supposed to be sitting and playing in the sandbox, the documentation was just horrid. That was the least. Now, the billing side and all that stuff, I'm sure it's elegant. I don't know, that's not my department.
It's a little trying.
On the provider
You
side,
know.
I'm just silly enough to think my notes are important.
Well, they are. They
They're
are.
kind of the basis of everything.
You know.
You know, in the courtroom, I don't think they're gonna hold up the billing sheet. I
depends on who's suing who. But
And for
anyway,
why,
it's all important, and we're not taking any of it lightly, and I think we just have to make sure that we know what's going on from every aspect, and hopefully whoever comes out to do the provider and the additional training, they're not builders, so they're not gonna be able to fix things probably on the spot, although they may be able to get conversation going back and forth and some fixes in the system. Any electronic health system that you go with is gonna have some issues and some problems.
Absolutely.
Not
I've been
to-
through
not to-
about
I was gonna say
3
that.
of these.
Not to
that
say
are
that
just-
Dr. Pafford's concerns are not very, very valid, but, you know, we will get there, I hope.
Yeah,
If we
will.
don't, we don't have a recourse other than we pay $800,000 for the system, and we go back to Tech Time and we say, give us your new system for $300,000 or whatever the deal was, and we update Tech Time and we go on, and Tech Time now costs us $1.2 million because we had to pay $800,000 for a system that we're not gonna be able to use. That's our only out of this. So we either try it and we put some effort into doing it, and we really try and make things work, and from my perspective, where we've come in the last few months has grown, and we're doing much more in the system. Are we there yet? No. And do we have great concerns? Yes, we do have some still. But, I mean, I kind of feel like our hands are tied. We either really try to put the last ditch effort into making this product work for us, or it's gonna cost us another $300,000 to get back on Tech Time and update it to a meaningful use product, so.
And one
There we are.
lawsuit will cost all of that.
It will.
That's right.
But we have some paper too, right?
I like Jen's suggestion though, to ramp up the heat a little bit, where we can, where we think it is possible. Somebody who has the clout.
And I will do that when I get back to my
And the
desk.
knowledge to
There's
make it
al-
happen.
There's already been some friction though, we have to do that, that has to be really delicate at this point.
Yeah, but we can't just hope that it happens. We
No,
need to be-
I agree,
We need to be
we
assertive.
need to keep the lines of communication open
Yeah.
And I think, I don't know, I'm always an optimistic person, but I feel like, exactly, it is what it is, that's what we have to make the best of it. We have to work as hard as we can to get the best out of the product. We also have to know that every product, there's no perfect EHR out there.
They all have these same
They all,
issues.
and if you talk to people who
Absolutely.
have gone Cerner, who have gone Epic, they have many of our same beefs. We're also in a time warp where all EHRs did this. They purchased, some were inpatient, they purchased outpatient, some were outpatient, they purchased inpatient products, and we're in this big time warp of catching up and doing things. So in my opinion, NextGen will either catch up on their hospital side and become a good company, or they'll go under. So, I mean, they aren't gonna continue poor and continue to run a company. So I think that being said, we're in a time warp, we just have to do the best we can, we have to work with what we have the best we can, and we have to be optimistic. Like I said, having someone come back, I know it sucks to pay $20,000, I don't know how else we're gonna get a lot of big issues resolved, that, like I said, unfortunately, there's lots of things that come out after you use the system for a while. I think the same thing, when we had clinic trainers, they came back, and by then you have this giant list, and even though we're paying it and saying it's for nursing and providers, everything is generated out of there. So that means that they'll hopefully fix glitches we have with lab, with x-ray, with billing, with, all those things. So it's just growing, we're growing, it's growing pains, it's ugly, it's messy. I'm optimistic that it'll either get better or the company will fold, and, that's the truth. So we just have to, do our best, have a good attitude, and work with what we have, and that's all we can do.
Thank you, Laura. With that, I'm gonna cut the discussion off with
I think
EHR.
Great idea.
Thank
Go on
you
and on.
everyone for your comments and for your participation in this discussion. It's very valuable for us to get a good picture of what's going on. Foundation report, Mitzi, can you update us on
Yeah, I've been
what happened?
it was a pretty quiet meeting. They're desperate to get new members, so if anybody knows anybody who might be interested, please send them to the foundation.
We have the same concern for our board.
I know. I know. They're,
There were
very-
weren't there two potential
Two
people that?
potentials, yeah, they have, I don't think they've fully committed to join yet, but, there are big pushes for the yard sale coming up, the.
What's the date on that?
June seventh.
June
June
7th.
7th.
Yeah, so they're asking anybody that has anything to donate to please get it to one of the members of the foundation or get it to
Maggie,
me or.
Monty, or Roger?
Yeah,
that okay?
yeah,
What kind of things are they looking for?
anything to sell at the yard sale.
Where is
Called
it?
Second Treasure.
Or the not junk sale or?
This ain't junk.
It ain't junk.
It ain't junk, yeah, okay.
It's also on the same weekend as the car
As
show.
the car show,
Yes.
and where is it gonna be?
It'll be across the road at the Masonic
At the Masonic
Hall,
Lodge?
yeah.
Right across from where the car shows.
Yeah,
Right,
that'll,
right.
that'll be high traffic, that's for sure.
Yeah.
Cool.
I have to go back to patients, but, two things, thanks for changing the strategic plan, so it's on a day that I can attend, thank you guys for doing that, and, two, words out, and I think starting to be out, but, I think our hospital needs positive things, but unfortunately it's a Superior / county-wide problem that lots of times we have events and nobody shows up, so there is free mammograms scheduled for May 8th. People do have to call a number, but try to spread the word, cause it's a bummer. Last year we got one person, and I checked yesterday, and I think we had one signed up, and I'm like, dang it, people will complain and complain and complain and complain that we don't offer things, but then they never take advantage of those
What's
things.
the
We have
recommendation
two
for
now,
that?
woohoo!
What's the recommendation? Is it 40?
40 and over,
40 and over.
if they have no insurance, or if they have insurance that doesn't cover it, then they can get them funding. And if,
Is that even possible anymore?
Oh, yes.
to have
To
insurance.
have insurance that doesn't cover it?
Oh, I don't.
Sometimes.
No, I don't
Yeah.
think that's possible.
I don't think that's possible
It, you never know, or it's a high
Yeah,
deductible
okay.
or whatever, some people.
So May
I don't
8th?
know. Yeah,
Call for an appointment.
yeah. Spread the word, cause I think. Anyway, I know.
That might be a good thing to send out on the all county-wide, email list.
It's a really good thing.
Things that change too.
And, yeah,
I think Monty's been working hard to get the word out.
okay.
He has, and I know there's
Thanks,
an
Laura.
ad discount, but.
Okay. Anything from the bylaws committee?
No.
Okay. Clinical outcomes QI committee, Gary? You had a meeting this last month.
Well, we were scheduled to have a meeting, last Tuesday, but there was lack of attendance, so we canceled the meeting for the QI, not the QI committee, but the clinical outcomes committee.
Okay.
There, from the previous meeting in February, under the inpatient pneumonia QI team, there was this question that Dr. Pappert had discussed about. We have a certain benchmark of giving antibiotics in the emergency room.
Right.
And in some instances, we're not meeting that benchmark intentionally because of cost considerations. You might wanna.
Oh, okay, so I'm speaking a little secondhand, but I've been in quality meetings where this has been brought up, and I understand that one of the measures in the world, if you come into the emergency department from the outer world, and you're sick, and we deem you to have a pneumonia illness, it's called community acquired.
Right.
You know, there's like 4 or 5 categories, and how you treat is based on where did you come from? Did you come from a nursing home, or did you come from the ICU, or did you come from your house? One of the benchmarks that they try to track is administration of an antibiotic. If you're going to be admitted from the ER to the hospital, you get that antibiotic in the ER. Okay, that's just how people do it across the country. It's a recommendation. It's not like if you don't do it, your hands are going to fall off. But it's a good idea. But the problem is, in our setting, there are economic considerations in regards to the patient. I mean, you give them that dose of that antibiotic in the ER, and it turns out it costs very differently than it would if
They
it were
weren't
given.
inpatient.
If you just scoot them down the hall 50 feet, it costs them differently there. And that's why on those reports, it'll show that we're not giving that first dose in the ER per se. I promise you that's not any intention on the part of the provider. It's just that we're a small community, small facility, and people tend to get in the ER, seen by a provider, and into it.
And it's not a lack of
Like
care,
zip,
it's
zip,
just
zip. In
person,
fact,
yeah.
it's, the problem is created by the fact that we can move so quickly. Okay, so if you look at that data and see that we're not giving that first dose in the ER, it's not that we're mean and incompetent, we don't like our community. It's because for the financial impact it'll have on the patient, and it's just smarter, move them down the hall and give it to them there. That's my understanding of it. Correct me if I'm wrong on any of that, Gary, because that's, I've heard it enough times from Kirsten.
Yeah, I've never seen the costing of that, but,
I don't know
kind
the
of taking your word.
Well, I'm not sure it's
Can
the,
I just clarify?
yeah, there
It's
you go.
not the
Yeah.
cost, it's not the cost, we charge the same in the emergency
Right.
room as the inpatient. So let's not get it out there that we charge differently for ER versus inpatient.
Right.
The cost of the drug is the same. What happens is in the emergency room for Medicare patients, some drugs are not considered payable under the Medicare Part A or Part B coverage. It has to go to their Part D benefit, which is their prescription drug benefit.
So you're saying they're not.
Has more to do with the
Right.
insurance
So if-
reimbursement.
The way it's
If
paid,
it comes in and is given in the inpatient world, they don't even look at what the drugs are necessarily unless it's audited, so
It's
it
all
goes,
bundled.
it's all bundled
Payment.
into,
Payment.
and there's an inpatient deductible left.
Okay.
On an outpatient world, they have an outpatient deductible, they're 20% copay, and any of these drugs that they've determined can be not, or administered differently, that they don't pay for. So that's the difference.
So that's it.
Yeah, we don't
Okay.
wanna,
So it
wanna
still
be-
hurts the patient.
it
because
falls
the
to the
insurance
patient to
company-
pay in the emergency room where it doesn't fall to the patient to
Is
pay
an
in the inpatient. It's
Because of
covered.
the way insurance,
It's covered.
It's a courtesy,
Yeah.
to
Okay.
the financial
Yeah.
courtesy really to the patient.
okay.
Yeah,
Right.
so
Done.
what we're doing is the right thing.
Exactly.
It just makes it
Right.
look like we didn't do it in the
Yeah,
ER,
so-
but that's okay because we're moving out of the ER fast enough.
Yeah, and I think we
Yeah.
just keep in mind that we're still practicing good medicine on these
Right.
guys, okay, so.
Yep.
Can't we make note of, it was fast, I mean,
It doesn't make any difference when you're reporting or benchmarking some of
No.
that stuff. It's either you did it or you didn't do it, and
Okay.
you're
Yeah.
100% or 0%.
you don't get to
don't
asterisk
get
that can say,
reasons.
this is the reason why, there's really valid reason.
Yep.
Okay,
Or we did it or we didn't do it.
okay.
Sort of thing.
The quant approach.
Gotcha.
Anything else, Gary?
The other half of the meetings is the quality improvement committee. We have the clinical outcomes committee, and then the quality improvement committee. So that committee just met. Larry attended, and he really put together an excellent presentation, I thought. And, you know, one of the things that he put out a memo here, just on the 17th, about, we were due for a Montana Department of Health and Human Services survey inspection anytime. And so it's important that we have an active working quality improvement program. So he put together a really good program in that we had her name is Kathy Wilcox. We had a conference call here with all the department supervisors. And she's the Rural Health Quality Coordinator for Montana. And she serves in that PIN, I don't know, you guys are familiar with that PIN report,
Yeah.
Performance Improvement Network?
Yeah.
Okay. She coordinates that, and she categorizes the hospitals according to their size and their services. We're in terms of peer groups, there's 5 peer groups. We're in peer group 3, so the larger hospitals that provide all the services are in peer group 1. Services like OB and surgery, et cetera. And then if it's a smaller hospital, then it gets down to peer group 2. In our case, for peer group 3, we're a small hospital, but we do provide some surgery. So then we're compared with about 5 other hospitals in Montana in our own peer group. And so we got a chance to talk with her, and each supervisor had a chance to voice, what they were doing with their quality. And some had ongoing projects, some didn't have ideas yet as to what their project should be. And so Kathy was able to offer some suggestions about what was going on around the state, and put some thoughts in people's minds about what would be something really good and meaningful to our program. And that there's new benchmarks being measured now, pressure ulcers, stroke, emergency room transfers, how are these being coordinated, medication reconciliation, and so there's several meetings that go on. I don't know if there's called a peer review, virtual peer review of clinicians that meet, a conference over the phone, and they take certain cases and they go through, evaluate those cases. And so it would be good if we had the time. Usually it takes about an hour for one of our clinicians to set in and discuss a case and get some ideas about what might be good or bad about what was being done. And then there's also opportunity for trustees that meet on a quarterly basis to kind of discuss what's going on in quality in Montana, in critical access hospitals. So that meeting is available. I think it's coming up in Livingston. And so that's kind of it. I thought it was a very productive meeting, and that hopefully some better things will come out of it, and we'll be ready for our inspections.
I know Kirsten had been really good about, for the quality improvement projects and whatnot, quarterly, to get the board updates on those things. You're still gonna get updates on the once this gets rolling, just make sure the board has updates on those. Thank you, Gary. Carol? Customer satisfaction
We
committee.
had one meeting a couple weeks ago.
You did, very good.
And people had projects they were working on, and,
What are some of the projects?
just the callbacks, and stuff like that, and, following up with the patients, and, they're doing some survey things, and,
Heading up that committee.
yes. So we didn't meet this morning, and we didn't meet last week, so,
I think this morning he had other obligations, family obligations, so he didn't get here till real late this morning. I don't know if that was, part of the reason that we didn't have a meeting.
yeah,
Last week there were several of us on the 2 workshops.
yeah, so.
When you guys get rolling, can we get maybe in our packets, just an update of what the projects are, and kind of who has ownership of those
Yeah,
projects, and as things, and as you guys gather information and just so that we get a better update on what's happening there.
Yeah,
That'd be
the
great.
last couple months have just been hectic.
No, I
because of
understand.
NextGen. We just haven't had
I know.
any meetings at all.
I know.
But
So once it gets
think-
going,
yeah.
just
Right, yeah,
keep that in mind.
Yeah.
That'd be great. Thank you, Carol. Okay, professional affairs, we don't have any privilege requests this month. I'm not aware of any coming up, but you haven't had that staff meeting, and Julie hasn't contacted me, so we'll keep you up on that.
I don't know if everybody realizes, but Julie's husband fell and they thought he fractured a hip or broke a hip. He had some hip surgery, but he really didn't. Did I hear that this morning? So
Well, he had
she's
had-
kind of been out of commission the last
He had a total hip about 2 months ago, and then on Monday morning, he fell, and so they weren't sure whether he was gonna have more surgery or rebroke his hip. Anyway, the result was he just tweaked it, and so he's in pain, but doesn't require more surgery or anything.
That's
He
good.
just has to get over the pain of it, so.
But Julie was pretty tied up with that.
Yeah.
So last week. she was supposed to be out on Monday, with the meaningful use lady from Helena, and couldn't make it because of that.
Okay.
To get back real quick to the customer satisfaction, after the
Go ahead,
meeting
Rick.
we had a couple weeks ago, I sat with Mitzi really quick and we agreed to send out a digital copy of our hospital newsletter to the community social media pages throughout the county.
Oh, that's
And-
great.
And based on some customer feedback that I got from a gentleman who had family in the hospital a few months ago, he suggested putting an email address in there for or for community comments, complaints, suggestions, otherwise. And so Mitzi agreed to add that to the newsletter, and so hopefully we'll start to just get some general feedback from the community, which I think would really help us
So
a lot. and
what
it's a good
email
start.
address was put on there?
Mine.
Yours?
We
Lucky
actually,
you.
we actually talked about doing that in the customer service committee, and we really hadn't come up with necessarily the appropriate person to do that, so if Mitzi wants to take it on, that's great.
But I think in that term, we've broken the ice, let's just say,
Okay,
and we'll
good.
move from there.
Good, very good. That's
Nancy,
great.
have we had any feedback from the article we had in the Miineral regarding the testimonials, that patients,
Of course not.
no, okay.
Sorry.
That was nice to see.
People are happy, they don't say anything.
That's right, that's right. That's true.
Well,
Okay,
Leona's not here again, I might add.
Yeah, good point.
We really need to couch that article in a different thing. To Middle County residents, what do you wanna bitch about now?
I have to tell you, Dr. Gardner and I were talking about marketing something, and we were, talking about how it's always the negative stuff, so I asked him if we could put his picture on the post office wall that said wanted, and then underneath just say surgery patients, and see if everybody saw it that way.
Just kinda talking about,
Yeah.
I haven't said too much, this, and that's probably a good thing, but, we've, Mitzi and I have been working this last month and pretty hard on getting some of those positive messages into the community. We've worked at this cooperative, ad campaign with the health center. Every other week, we're gonna do an ad, and we're focused on, the good things that happen here, and the good feedback that we do, and just the word of mouth, if everybody can, that's probably the most powerful thing in a small community anyway. We can't afford to do too much of this, heavy-duty stuff that costs us money, but, there are just so many good things that do happen. All the people, we talked a lot today about the NextGen system, but it's just unbelievable the amount of hours that the nursing staff and the clinical staff and the medical providers and everybody have put in on this thing, and sometimes that doesn't come across, when we focus in kind of management by exception, on the issues and the problems, but there are many, many good things that happen around the hospital. Trying to get that message across to the community. Gary talked about this when I came 6 months ago. It's kind of been his theme, that what are we going to do to turn around the perceptions of the community? And I do sense in the last couple of months that we've made a little progress on that. So we're trying to be more visible in the community. I'm trying to get down to the commissioner meeting.
That's great, you have 3 meetings coming up.
Right, another round of town hall, and Kim told me yesterday that she's gonna be here both days next week, Wednesday and Thursday, so she will be able to, we thought maybe Bill would fill in for her on one day, but, she's gonna be here, and, we can get around and hear what people have to say, and make sure we address their concerns and all of that.
very good. Okay, moving on to unfinished business, hospital district board position, so just kind of update everyone where we are with that. So we put ad in the paper over the last few weeks, it was over 2 weeks, last week and the week before that. The deadline for applications was on Tuesday, and I just contacted Stacy at the clerk and recorders, and there were 0. Jim did submit a letter of interest to the commissioners, and I have I didn't expect those who had already applied to apply again, cause you had just applied like a couple months ago, so, for Virginia. But we have 3 spots, so we still have 1 open spot. The other 2 applicants that we had, in January, Tyler's moved away, so, he's not, he hasn't responded to my, I wanted to verify that, Jim told me that he had moved away.
Yeah, definitely.
I,
Working in Plentywood.
okay, that's what I understood. I was trying to get
He can't commute
confirmation
back
from,
from
I was
there.
trying to get confirmation from him, but he has not responded to me. And Robert is running for sheriff, and he can't hold 2 elected positions at the same time. And so I sent him a message saying, you know, we'll hold on to it if you would like to, pending the results of the election. I mean, obviously that is a higher priority for him right now. So we do have 1 open spot. I don't know what the board would like to do with that. My personal recommendation would be to have Jim and Virginia for one of those 3 spots. I don't know which ones you would prefer. We have the 1, the 2, and the 3-year that we could recommend to the county commissioners. Ultimately, they can do what they like. Right, Lori? So, thoughts?
I'll leave it to the commissioners. You let her flip a coin, doesn't matter to me.
Does anyone have anyone in mind that they could talk to?
I talked to Mike Wood,
Yeah?
he told me to think about the ex-mayor of Superior. He's my Sunday school teacher.
So at this point, we can make the 2 recommendations to the county commissioners. Do you have any thoughts on that, Lori?
Well, I mean, I'm
It is what it
assuming
is.
Jim would probably want the same position that he's, wasn't the 3-year?
Yeah.
Yeah. And then, you know, Virginia could probably the 2-year term, and then we'll just hope that we get somebody for the 1-year term.
Do we need to have an official, do you want applications? What do you think the county?
Well,
the
no, all
commissioners
you
want to
need
see?
to do is just
Just
come with
have them.
recommendations that this is who, you know, we want to appoint to these positions, and then, you know, we'll appoint, and then they'd have to go to the clerk and recorder center probably.
Sure, and do the oath of office.
Do the oath of office.
Okay.
It might be easier if people know it's just a 1-year term.
Yeah.
That might be easier.
It's an easier commitment.
Yeah.
Although 1 year, gosh, it's a steep learning curve.
Yeah,
It is a
is.
steep learning curve.
Actually,
So-
that's the one I would be interested
Oh.
in.
Is that the one you'd be interested in, is the 1 year?
If, yes.
Okay.
I'm still kind of undecided. These are long sessions and I'm,
Well, let's make that recommendation then for the 1 year instead of 2.
okay, because I'm getting older.
I understand.
I need to retire from my retirement.
So should I contact Cindy to get that on the next, commissioner's agenda? Okay,
Probably next Wednesday.
next Wednesday.
Because
then
it's
if we
too
find
late, it's
somebody
too late for
interested.
tomorrow.
Right,
We find somebody that's interested, we have them contact you, Amy, or the commissioners, or both?
Probably both.
Yeah.
Probably
well,
both.
Simple letter.
Yeah,
I know I spoke to Bob and he's interested in the board position. But like you say, you know, if he doesn't win the election as sheriff, he will definitely jump in as board.
yeah, and we'll know some of those after the primaries, but
Right,
we'll just,
not until then.
we'll see, okay. So I'll do that, I'll go ahead and, contact Cindy to get that on the agenda for the next, meeting. And I guess I can go and do that recommendation. I'm not a district member, but as chairman of the board, I think it doesn't matter. Yeah, I don't think it matters. Okay, do we need to vote on this?
No,
I don't think so.
From what I
I don't
read,
think so.
I understand that if we miss the filing date, then it's up to the board to submit the names to the county commissioners.
that's how we,
Right, that's what we're doing.
in the statute, the board does, technically, the board doesn't even have to recommend names, it's up to the county commissioners to, appoint someone at that point to fill
Yes,
those
but they
terms.
usually
But
do.
that's how we're doing it is, we're gonna make a recommendation, for the county commissioners to appoint.
Right.
So, that's right. Okay, moving on, update on workers' comp insurance switch. How are we going with that?
I guess we're set to switch over
Are we
on
set to switch?
July first, right?
Right,
July
For the
1?
Montana Health Network. I think Larry's still working with Bob on the letter of credit and getting that released.
right. I attended a MHA, we're switching from the Montana Hospital Association to the Montana Health Network trusts. Both of them are employee trusts. And we're doing it for money reasons.
Yeah.
I think I've explained that before. We were hoping, I think in one of the blurbs I sent out to you lately, we were hoping that we might have a quarter forgiven. I attended that meeting, a week ago last Monday. It doesn't look like they're going to forgive a quarter. There's a possibility maybe they would forgive 50% of a quarter, because apparently the experience has not been real good with their other members. Our experience has been excellent. I mean, as we've talked before, Stacy does a great job of reducing our risk, and we don't have claims. I mean, we just don't have claims. I did have conversation with Jan Bastian. Dick Brown has been reluctant to kind of commit to releasing the subscriber savings account, which we have about a $61,000 balance, I think, in the subscriber savings account, and we have $36,000 letter of credit, both which should be released, especially if our claims experience on the workers' comp side is good, which it is. It's the history is excellent for the last 5 years. Jan Bastian advised that.
Who's Jan?
Jan is the CEO. She's the executive director of the Montana Health Network,
Okay.
the one we're going to.
Okay.
And she's very good. She's been around risk products for all of her career. She's really an expert in risk. And Jan indicates that this happened with a couple of other hospitals with the same trust with MHA. Both St. Pete's in Helena and Community in Missoula both exited from that trust, 2 years ago, Stacy? A couple 3 years ago. Jan said, well, the way to resolve it with Dick, we certainly, as I've expressed before, we want to stay friendly with Dick, and the hospital association. We rely upon them for a lot of other programs. We don't want to have this be an unfriendly divorce, but what they ended up doing with those two bigger facilities was just going to the insurance commissioner who sets these rules and regs, and you have to lay out your case, for getting either or both the subscriber savings account back and the letter of credit. I did notice on the reports that we were looking at a week ago last Monday in Helena, for that trust, for the MHA trust, I'm switching back again here now, but they are still holding on to the subscriber savings accounts for both those bigger facilities. So I think the best option for us is probably going to be, the $36,000 in terms of the letter of credit. It does bring up a problem. It's just something we have to work through, and we have to talk to the bankers about it. But the letter of credit that we're going to have to provide for the MHN trust is $50,000. So we'll have to go to the bank and see if they're willing to work. First of all, we have to get the letter of credit released, and then Cliff and I need to go to the bank and the bankers, the local bank, Mullen Trust, who the letter of credit is with, and get that and address that issue. See what kinds of collateral they want, or how we work that out. So, but I think it's all very doable, and we're rolling down the road. So that's the current status with that whole thing.
Okay. Thank you, Larry. next item, proposed write-off of MRHC.
Well, this is
debt.
that issue, that came up last month from the audit, we had some discussion, but we didn't really finalize it.
It's about how much?
Well,
It's about 300?
yeah,
Is that what we're looking at?
yeah, it's kind of a tough issue between us and the clinic, it really is. Well, the audit amount, I don't know if you picked it up in the discussion with Tom Dingus last month, but, I mean, he's auditing the previous fiscal year, and the number at that point that's in debate or under discussion was about 700 and some thousand, I think. But, it's the understanding, well, I guess it's the opinion of Cindy Sturgar and Kim, and the health center board that the hospital agreed to write this off, that amount off. Going back a little bit further, John Earl, the CFO through Miineral on the other side, on the health center side, met with myself and Cliff in a series of meetings to identify we owed them money, they owed us money, but, bottom line was, this hospital cash flowed them for, a couple of years, since the time from the time that the FQHC, the Community Health Center program was set up over there, up until really January 1st. I mean, we bankrolled them, we did do that. And there was a series of meetings there to identify, the ins and outs. And it's very difficult to do that. The records, they're there, but it's just a lot of complicated stuff going back and forth. But Cliff and John, identified in some working papers a $305,000 amount, I think, that was contained in a memorandum of understanding between us, where we say, it's the opinion of the health center that the hospital forgave that. I don't recall any discussion ever, with the health center or John or anyone, or Cindy or anyone on that side, that we agreed to forgive that. First of all, I don't, why did we go through this memorandum of understanding and recognizing this number? Why did we even bother if it was going to be forgiven? It just, the memorandum of understanding does not say that it's going to be forgiven in any way, shape, or form. And I would have never signed it, if that had been the case, so.
Wouldn't the board have to vote on that?
Well, yeah, I mean, that's the bottom line, even if he did say it, it doesn't, only the board can do it.
Exactly.
So that's the bottom line, so there's nothing binding.
Right,
At
exactly.
this stage.
Well, the memorandum of understanding
There's some
itself
things
is
that
not
are
binding.
complicated, that complicate the situation a little bit, I think. And is that money uncollectible?
Yeah, I think it is. That's the opinion of the auditors, yeah.
If the money's uncollectible, and I know that, it's my understanding that it's holding up the health center's ability to partner, because the partner is unwilling to take on that debt.
That's correct.
The other question I have about this situation is there an ability to recoup some of this cost through cost reports, or through, is there ability to be able to recoup some of that cost if we do write it off?
I don't know the answer to that question, Cliff.
Or is it an outright loss?
I don't think you'd be able to recover it, I don't think so, but I'm not 100% sure of that.
Yeah, the one place there might be a possibility that I can think of, the reason it ended up down at 305 versus 700 is there were some offsetting things that the health center did for the clinic.
Right, that's correct.
And I don't know exactly, I know one of the, I think, bigger ones was that health center doctors were covering the ER without the clinic ever getting paid for that. So that's one of the offsets. What the others might have been, I don't know. But that's how
Well, there were a
down
lot of
to the-
transactions, I can't remember
Yeah.
the detail either.
But that's how it got down to the 305.
Right.
It might be that some of those numbers, since they were legitimate hospital expenses, maybe could get built back into a cost report. Maybe, I don't know. And I say that
maybe.
without, I
Yeah,
say
I
that
don't-
without a lot of understanding of
Well,
what
no,
goes
I
into a
don't
cost
think so,
report.
because, I don't know.
I mean, what I'm saying is the only
That
thing that
brings
could
up a
go
big
into a
issue,
cost report
that
is a
brings up a
hospital
big issue
expense.
with the feds though, because they can't work on both sides. I mean, you know, the physicians can't, and the mid-levels can't work on both
Well, and
sides.
it's
So
not
if you
big-
recognize it on our books and also their books,
Well, it's not being done anymore, and they know
Right.
that we have stopped that working
Right.
on both sides, so
Right.
whether it would be an issue, and maybe it can't be, I'm just tossing this out as something to explore.
I think we
I'm
really
not
need
saying
to
I
have
don't
Cliff
care.
involved in this conversation.
yeah, we do, yeah.
Um,
Yeah. Well, that part of it as far as the cost report, but I don't know that we need Cliff to make the decision as to
No,
whether
but I
we're gonna
feel like
do
I
this
don't
for
have all
business.
of the information.
We need to get the audit report.
I feel like I don't have all of the information that I need without Cliff here. To answer my questions.
Well, maybe we can address it, I mean, we're tardy with that audit report already quite a bit, but, you know, we committed and promised to you that as soon as we get the numbers for March, you know, which we didn't have because of the NextGen conversion, we have a special board meeting or something, you know, we might be able to, I'm not sure when we'll have those numbers, but if we do, we can certainly put this issue on the agenda again and have Cliff here to discuss.
Assume a worst case scenario that you can't recover any of it on the cost report. And that's what we're looking for from Cliff, is there any way we could recover any more?
Is it gonna change our
Is
decision?
it gonna change the decision?
I don't know.
And it doesn't for me, because I think the bottom line is we can't collect it anyway, and it's not gonna be more collectible if we can get some of it on the cost report or not.
So what are you saying, John, though, that you would lean toward, writing it off?
Yeah, if you can't, just like we do with, money that's owed to us by patients that we can't collect, you write it, you don't keep it on the books forever and chase it.
I mean, that would be the position of the auditors. I don't know, the leadership team, we've kicked this around quite a bit. It doesn't sit well with us, I guess, with management that we cash flowed those folks for a year and a half and it's not recognized.
Well,
Does it have to be a complete write-off, or is there some ability of the health center to pay some of it back?
Well, one of the things there's an ability the health center to maybe do is something else the health center's looking at doing, and that's, injecting a $350,000 grant into the hospital by buying this building.
Which is another,
And,
yeah.
you know, it's not like the health center isn't prepared to try and help the hospital where it can help the hospital.
Right.
But, I mean, if it's not collectible, recognizing it by keeping it on our books, what does that do for anybody other than make it harder for the health center to do something
With,
on their end?
partnership, with partnership.
Yeah, they can't get an MOU without that being cleared up.
Yeah.
Well, yeah, Kim explained that, you know, that their board is unwilling to accept that liability, you know.
Yeah. There's no plus side to the hospital by keeping it on the books as a debt. There's a negative to the health center. And I think it's as simple as that.
I mean, it's a board decision.
I think that John and Jim should recuse themselves for this.
Amy, we had planned on that.
I know, I
Yeah,
just.
there's a difference between discussing and voting.
You're right.
And I'll even close mine.
No, we don't have to close your eyes.
Maybe for Adam's benefit, we have several members here, a couple of members that cross.
But I mean, the bottom line is, we need to look at what we're trying to accomplish, and what we're trying to accomplish is provide health care to Mineral County, the best way we can.
That is our goal.
And keeping that
Is-
debt on the books, if it's uncollectible at the hospital, does nothing towards that goal at all. It does have a negative impact in terms of the health center's ability to make some changes that are changes designed to meet that goal.
Is it all uncollectible?
I sure think it is. Auditors seem to think it is. We're barely at a cash flow break-even point over there right now, and we're at a cash flow break-even point because we're collecting some accounts receivables that are back there. If we were just working on our current, we lost $2,000 this month.
Can I ask, just throw in a
Go ahead.
totally unrelated question? Are they gonna get any meaningful use money back from their providers? They have 2 providers that could meet meaningful use, are they, I mean, there's a possibility of some money coming in that could be captured as well. I don't know what they're doing from the clinic side.
I don't know the answer to that question.
Yeah, well, there are a lot of pluses and minuses, you know, in terms of the transactions back and forth. There, you know, certainly have been, and, you know, we certainly are still, you know, we certainly are collaborating with, you know, the clinic folks to, you know, to move everything forward. There's no doubt about that.
And one example of that, and another way to look at it, that it was just I presume the ads were split 50-50, is that correct? And the clinic's not having any trouble really finding patients right now. It's the hospital that is, but the clinic went 50-50 on the ads that are focused on finding patients, so.
Right.
It's not.
Well, they're certainly having trouble finding patients. I mean, they were at probably 10-year lows both in February and March with their patient numbers.
Well, that's what they can see. They had a whole pile of Dr. Smith's patients trying to beat down the door.
Yeah, I mean, it's a board decision. I mean, you know, whatever you direct us to do, we certainly will do.
Well, you know my opinion. I'm never shy about that.
No.
Well, what's the health center
Gary?
want us to do?
Oh, they would, as John, in my discussions with Kim, they certainly, they have an issue if this appears on their books with the partnership board in Helena. You know, and you know, if I were sitting on the partnership board myself, I mean, I would certainly have that issue too. I mean, you know, they would be worried about having to pay this. I mean, you know, and they're accepting a $305,000 liability at this point in time.
Did they have a request for the hospital to forgive that? Or
Yeah.
Is that on the table?
Yeah, that's what.
Yes.
That's what this is.
And maybe, let me explain a little bit more about what's going on with the whole partnership thing too, because perhaps not everybody on this board completely understands that. One of the big sources of funding for the health center is this HRSA grant. It's over $700,000 a year. It's roughly half of our total revenue. When the HRSA grant application was filed, among other things, and that was an application filed by previous management, it basically said that the health center was going to see X number of patients a year. That we don't see anything like those numbers, and it's totally unrealistic to and most of the people in Mineral County would have to come to the health center on a regular basis. It's never going to happen. It's not even close. Which creates a real risk with our HRSA grant. However, we're talking about basically combining, and we haven't worked out all the details, but perhaps even becoming a part of Partners Health Center Clinic in Missoula. They have more patients than they need for their grant, and combining the two, we can use their excess patients and meet our grant requirements and not lose our $700,000 and some a year. Additionally, we don't have to have a separate CEO. We can use some of their services down there, use their CEO, et cetera. So there's some other savings. There's also the potential to bring some additional services into the county from partners. They've been bringing up already, they have a mobile dental clinic that they brought up a couple times, and things like that, so that there are things that, because they're larger, there are additional services that we can then bring to Mineral County. Their board does not want to take on a $300,000 debt in the process. So that's kind of what the background is for why we're looking at that direction and why this is particularly important.
Good, thank you.
Any thoughts? Carol, Virginia?
Well, I don't know that much about it, but from where I stand right now, it seems to me that it would be beneficial for us, the hospital board, to forgive this portion of debt or whatever, because if the clinic increases its numbers by referrals from Missoula, and some of those people live in this area, go to Missoula, so that's where the overflow would be. And if we have good relations with the clinic over here, which we do, but keep it up, you know, by the forgiveness of this amount, then those people then become more familiar with us, and it will in turn, over time, increase patient referrals to us, instead of them having to go to Missoula for those services. If we provide the same services, they would come here, because it's closer. They've become familiar through the clinic. That's just my thought on it.
Carol?
Well, I certainly don't wanna vote on this without Clifford being here. I'd wanna have Clifford involved with the discussion. I mean, I can see how this is. So I don't remember the board voting on the 700,000 covering the clinic. Did that happen?
We didn't, that was something that just happened because the finances weren't separate.
Oh,
It was all mixed up.
okay. Yeah, I wouldn't wanna vote on this subject without Clifford's input, so.
You know, I wasn't here at that point, but, you know, certainly wasn't, but, I think that, you know, I think Stacy and Cliff, you know, kind of pieced this thing together for a long time, you know, because the money was commingled like that, the cash flow was,
Are we at the point now, though, where if we do write that off, that we're not gonna be in a similar situation? Are we confident that we're not gonna have to bankroll the health center
Well,
at some
that's-
point in the future?
that's what galls us, I guess, you know, I mean, you
If-
know, they've healed up, I guess, in the last few months.
And if that's
We have
true, and
not.
if we're confident
You know,
that.
we have not, so why don't we keep that on the books? I mean, they owe it to us, in my opinion. I mean,
Right, but if it prohibits them from being able to do, operate as a health center, then we all go under.
Yeah.
Is the other side of that too. Go
I disagree, I don't think we all go under, I think we absorb them and move forward. And that's a very real possibility, you know.
Well, you have to absorb them with a $735,000 or $750,000 less to run the whole operation on, because the HRSA grant goes away. You gotta remember that.
That's true.
It sounds like, I'm not an accountant, guys, I can barely balance my checkbook, okay? Bleeding to death, I can help you. Okay. But it sounds like, they're genuinely, and I don't know how you feel about the building. I don't know how you feel about this building, but if it's a matter of cash flow, and it sounds like if they make a few inquiries, they might discover that they will be allowed to use some of those other funds from previous grants to acquire the building.
Right, we've been
Maybe that would
working
be a
with them on that.
specific agreement. Is that illegal, unethical? I mean, is that just a bad idea? I mean,
trade off that debt for
Yeah,
that.
no, you couldn't trade it.
But I'm just saying, they purchased a building legally, which is, I think, a matter involving the county and other parties
Right,
involved,
yeah,
things
we're
along
waiting to
those
hear back
lines.
from,
But I mean-
Marshall on the procedures on
Yeah.
that, but,
He
I'm
has
just
a
curious.
question.
I might be swimming upstream here, but I'm reminded of how many times have, these hydro dams been sold in Montana?
The what?
The hydro dams, the dams,
With
Yeah.
Montana Power.
power plants.
mhm.
We're going through the second or third sale. We're still playing the same game in there, I think.
Well, no, we're not, cause the dams, the ratepayers are paying for it
Well,
each time
true,
around.
but
Yeah,
I gotta go back and ask a question. So far that I've watched this thing unfold, we've created two separate boards. We're trying to build MOUs. We're building protocols for the professionals who work in the clinic and the hospital. We're making this arrangement and that arrangement. I asked myself, what was wrong with what we were like before? We were doing all right. The only difference is the HRSA grant. We've got a building in St. Regis that we don't know who belongs to. It's owned by the hospital. They're asking in St. Regis, what are we gonna do with it? It's up to the clinic,
It's up to them.
it's up to the hospital. There's so much confusion that, I just wonder how far ahead, how much improvement we've made in this split.
I think there's two things to look at, and, I mean, certainly, first of all, a lot of the right questions maybe didn't get asked before this happened, and you guys didn't get the right information about the extent to which it had to be a split. But the other thing is, healthcare's changed in the meantime as well. Look at all the stuff that was out there in the news about St. Pat's cutting $5 million out of their budget to deal with the fact that healthcare has changed. I think some of the things we're facing, we'd have been facing anyway because healthcare is changing.
Sure.
I mean, perfect example, the NextGen and all of that stuff, that's something that was a big expense to the hospital that we had to do whether that split happened or not. So some of that, I mean, we'd be in a different place than, we wouldn't be where we were if we'd done nothing, because where we were doesn't exist anymore anywhere. It's changed. But we are where we are today, and all we can do is look at where we are today and try and go forward. We can't go back, because back doesn't exist anymore. And you look at it that way, and you say, okay, what's the best approach? Are we better off reabsorbing the clinic and trying to do it without that $750,000, fill in that $750,000 cash flow hole by reabsorbing? Yeah, by reabsorbing the clinic, we'll cut maybe some duplicated costs, but we won't cut $750,000 worth of duplicated costs.
We have $250,000, a little over $200,000 in duplicated costs just by hiring the hospitalists during the day in the hospital. So I think if you added to the overhead that you would slim down, it may not balance out totally. I don't think it would, but it would come very close to the $300,000 that the rural health clinic was subsidized already.
And it might do that, but it's not gonna come to $750,000.
Yeah,
So
probably.
we're gonna have a bigger hole we have to fill. Additionally, we've got this other $350,000 worth of cash that is, with this being as a separate clinic, it may be able to inject in the hospital by buying this building. If we don't have a separate clinic, the hospital's not gonna get that $350,000 in cash either. So you've got another big chunk that you lose if we don't get that direction. Then you've got Partners. Some of the patients we've lost are going to Partners in Missoula. By hooking up with them and essentially setting up a relationship or becoming part of Partners, we can hopefully get some of those patients back here. And even if they keep going to Missoula for a particular reason, they can be referred back here, for PT and things like that, so there's an advantage there as well. I think it's a win-win all the way around, and I think, you know, as much as maybe if we've been given the right information, and this predates me, but if we've been given the right information, we might have done something different with the clinic. We can't go back there today, it isn't gonna happen. Some of that debt on floating the hospital or floating the health center came into existence because bills weren't going out for an extended period of time, and it ended up having to be written off because it got so old you were never gonna get it anyway. So you aren't gonna ever fix some of that.
Yeah, it's a complex issue.
So the question comes, given where we are today, what's the best thing we can do for healthcare in Mineral County? And I don't think anything else, feeling like they got an advantage, the health center got more of an advantage than the hospital or anything else, is where we should be thinking. What's the best thing we can do for healthcare in Mineral County today? And I think that is to let the health center go ahead with a relationship with partners, which brings in more care, and it's to let the health center get in a position where they hopefully can buy this building and bring $350,000 into the hospital that otherwise isn't going to be there, and it's to
What's the likelihood of that happening? I mean,
well,
that's not a done deal either.
it's not a done deal. Everything we've heard from the grant agency, and this is, I'll tell you right up front, I want to be fair, it's secondhand, because I haven't talked directly to the grant guy, but I understand from Kim that they seem to be on board with that, and they're probably going to have a final decision pretty quickly. We haven't really heard much of anything from Marcia about the mechanics on the county end, so that's the only thing that's kind of just totally up in the air that I don't know how to address. I don't see why, usually if you want to do something and everybody's on board, you can find a way to do it, but we haven't heard from Marcia, so I don't know.
My last conversation with Kim about the clinic was that the project people back in DC were asking a lot of questions because that grant was originally a school-based grant, you know. And, what does this grant have to do with schools? I mean, her bottom line with it was, as John just said, it's not a done deal, and don't count on that happening. I mean, it's not a done deal.
No, I can't give you a guarantee, that's for sure.
That's
I agree.
not necessarily even related. I mean, that's not,
You're right.
that's not, that shouldn't necessarily have
Not for
bearing
this
on
decision.
this decision.
Right,
It
you're
should
right.
have bearing on
You're
this
right.
decision.
And again, the other part of that is you say, okay, putting that totally aside, this decision is either we write it off or we don't. If we don't write it off, we're still not gonna collect it. It might increase the odds of you getting the clinic back and having to run it with $750,000 less money to do it with.
Well, I would follow Carol's recommendation that we wait till we hook up with Cliff before we make a final decision.
I think we should have a special meeting.
That's what I was gonna say too. Cause
Well, we may need
we're
to do
gonna
that
need a
anyway.
meeting for our financials.
Right,
Anyway, and I would like to have
Right.
Cliff here, and I would like to have, be able to have this is a really good discussion, we need to have this. I'd like to have our finance guys input
Right.
on all the intricacies
Yeah, I'm
of
sorry he
that.
wasn't here.
That's
He really
okay.
was quite ill today. He just didn't feel good at all. And it's pretty unusual for Cliff to
What
do
what
that,
kind of
but
a
he went home.
timeframe is Partners looking at?
I don't have a solid answer on that. We've been trying to put together a meeting
We
with our committee and their committee, which hasn't happened yet just because of schedules. The latest I heard is it's probably gonna happen next week, but I don't have a specific on the timeframe.
Yeah,
Because-
that's exactly.
Well, my
what-
thought is, if we can do,
Kim submitted this report to you guys, and, you know, she said that same thing, that, you know, she's working to schedule a meeting.
Yeah.
with
Yep.
partnership.
because I think it might be beneficial to have the other board here as well. I think they are part of this, I mean, I don't know if we can do 2
Joint
weeks.
We're
And
meeting
have
on the same
financials.
day anyway, or we have, I don't know.
Yeah.
Did you split away from that, John?
Looks like that's gonna split away.
Okay.
Can we schedule a meeting, will financials be ready in 2 weeks that we can do our financials?
I don't know the answer to
You
that
don't know?
either. We'll sure
Can
let
we
you
wait till
know.
Cliff gets back and then we can,
He should be back in.
let us know
tomorrow,
when we can
next.
do that, and
Let me-
we'll, we can post notice and whatnot for public.
Okay, let me do one more thing, let me talk to Kim and see if she feels there's any time pressure on the one half of it.
That, and that's
And-
important to know as
yeah.
well.
And, cause I don't know the answer to that. I'll check that out, I'll get back to you, and then if we have to have 2 special meetings, we'll have 2 special meetings.
We need to get this resolved, and my question for Kim would be, is all of it uncollectible, or is there a portion of it that we can expect to collect? If we can say, if we have to, you know, if we're at a point where it is all 305, or maybe there's 50 that would be considered collectible, you know, I don't wanna write all of it off just cause we write it off. If there is some portion that is collectible, maybe not all of it, but maybe a portion, I don't know.
I'd like to see the thought
That
about
might
it.
be, that's a question I would have for Kim and for,
Especially with us having the cash.
but I think it would be good to, if we could all get in the same room.
I just think
off
that,
our bill.
that one thing that this board needs to know or understand is where does the FQHC really stand, and do they have additional monies, just like I threw out the question about meaningful use. I mean, if they're working on getting some dollars in for meaningful use, is there some possibilities that they're gonna have some cash that's gonna be coming in that has not been identified or looked at or asked for or dealt with, or, you know, I mean, we have the possibility of 2 docks that could have meaningful use coming in that, you know, we may have some possibilities on. I have no idea where the clinic is on any of that stuff.
And if it comes down to it, John, I think
Yeah.
when it comes down to it and we see it all laid on the table, we can say,
Does it
yeah,
make
that,
sense or not?
it doesn't make sense or not, and that's however we need to move forward. I don't think that we're 100% averse to, at least I feel I'm not, absolutely no, we're not gonna forgive this debt, I don't feel like I have enough information to do everything at
Okay.
this point, with all the input that I feel like we need.
Okay.
I wanted to throw out just the thought of pro forma. In other words, we forgive the debt, but they, based upon their increased hopeful utilization by this amalgamation, the partnership, that we have some kind of an agreement that they would somehow reimburse us, you know, based upon their increase.
I don't know if we could do.
I don't know,
I don't
I'm
think
throwing
you
it out,
can,
it's a
yeah.
possibility.
Break star clause, I can tell you that right now. You can't-
Well,
you have to be
one thing
careful
Cliff
with that
has
stuff.
talked to me about, is maybe it's, I hate to prolong this, but it's, here we go again.
Yeah. I got an hour, and I gotta go. So,
I got a plane to catch, so. Yeah.
Well, hopefully, Tom Holding will be here too.
soon, yeah.
But, you know, Cliff did talk about, you know, the clinic paid rent to the hospital, $5,000 a month, and we forgave that, up through the 1st of June, I think. Effective the 1st of January, you know, when we separated all the finances and stuff, as a courtesy to them, to help their cash flow. But their cash flow is healed up, ours hasn't, you know, and stuff. You know, if they do have some money, maybe, you know, I think that's very appropriate. I mean, you know, in terms of Stark, you don't have, Stark is a thing that,
Iron Man? Oh.
no.
That's what I think it's starting.
No, it's a law that, you know, you can't buy, you can't mix those kinds of things in terms of referrals and stuff. You have to keep an arm's length transaction when you're dealing with physicians and physician issues and mid-level issues, in clinics and hospitals, unless you own them, you know, like the old rural health clinic, you didn't have those issues. But this way, when you're separate like that, it adds some complication. That's what Deb is talking about. But you know, maybe that's one way to approach it, that in terms of the payback, that they will start paying. And I think that was Cindy's intent when we worked out that memorandum of understanding, that they would start paying rent when their cash flow heals up, which it's maybe not positive yet, but it's at least breaking even if it continues to improve, kind of like Gary's suggestion here. That would be one way to handle it, maybe, you know, to at least, you know, get some cash to flow back on this side and work it out or something. I don't know.
Well, and if they don't buy the building, I think that makes perfect
Yeah.
sense.
Right.
And there should be rent, if they don't buy the building, if.
Well, the
they can
federal
use
law
the
says
grant.
there will be rent, you know, at fair market value.
Right,
Right.
yeah, no,
I'm not sure that, you know, 5,000 is the appropriate
Okay.
amount.
So if you can both get back to what kind of time frame we're looking at, when we can have financials, we can schedule a meeting where we can make a decision.
Yep.
Does that sound good?
Yep.
Okay,
Geez, we get hung up on a few of these, huh?
I know. Okay, this one should be fast. So this was on the board, the CEO contract extension. The way that it's structured right now is it's on a month-to-month basis. I don't think we have to necessarily vote every month if we wanted to say extended for 2 months or whatnot, but we still have the monthly contract extensions. That would be for Larry's contract. So, and it's a 2-week notice, so yeah, basically we're extended through May 28th, but our next board meeting is until like a couple days before that, so that falls within that 2 weeks, so we gotta do it before that. Anyway, so we need to do, if the board is agreeable to that, extending Larry's, contract, we do need to have that.
I move we extend Larry's contract.
I second it.
For how long?
4 months.
Let me offer.
I've talked to his wife, it's fine.
Let me offer an amendment to that.
Yeah.
We extend his contract on a month-to-month basis until further notice. Then we don't have to address it we extend it on a month-to-month basis until such time as there's a decision to do something different. So then it can just keep going, it doesn't have to come back on the agenda in 4 months or 6 months.
That sounds good.
Okay.
Second.
So, okay, thank you. Okay, so we had an amended, motion, in extending the CEO contract, on a month-to-month basis until further notice. All in favor?
Aye.
Any opposed? Okay.
You know, if my
I
wife
have
ma-
that paperwork.
If my wife
I can
makes
take
me
care of that
give I can give the 2 weeks notice on my side too. She might make me do that. One of these days. I hope not. I don't think so.
I think we'd have to sit down and have a chat with her. Okay, board training and education. I don't have anything other than what we had in our packets. So if we can go on to new business, the May 21st mini board retreat. That is when Dick Brown can come. Is that correct, Larry?
Yeah, that's correct. It's
Um,
Wednesday the 21st, right?
Wednesday the 21st.